Okay, let's get started. February 4th, Wednesday here. Over to you, Simon.
All right. Okay. Let's see. I've got some questions. Can you explain the mechanics of reverse full face mask? Mentioned in your lectures, it can create a downward rotation of the maxilla and mandible. Can you explain what dental and skeletal movements we should expect to see in a primary versus mixed dentition? So reverse full face mask is done by anchoring the maxilla to a face mask, an external face mask. So it can be done with our stage 1 appliances with a face mask hook. It can be done with fixed appliance with the hook welded in, soldered in. It can be done with TADs or bollards screwed into the maxilla for older patients. So the mask sits externally, usually rests on the forehead and the chin. And you attach elastics to that mask and it anchors the maxilla via the hooks that are built into the appliance. The mechanics are just through the force from the elastics. Normally it's either 8-ounce or 16-ounce elastics is the common ones that are used. Recommendations is usually at least 8 hours a day, as much as possible. And the vector of pull usually determines how the maxilla and the mandible move. The mask relative to the elastics are hooked onto the hooks that usually sit above the gum line of the upper canines, sometimes as high up as the sulcus if it's like a bollard. And it comes out through the mouth to attach to the mask. The vector of force is always forward and down because the mouth aperture is usually lower than the hook because the upper lip gets in the way. And so the pull is always slightly down and forwards. In addition, almost every malocclusion is from an open mouth posture of some description, and the growth of that maxilla is always down and either back or forward. So there's always a downward component to it. And we have that is the pre-existing vector of the growth already. So when you're pulling, it's almost impossible to pull upwards because the lip gets in the way. So you're always pulling basically in the direction of the existing direction of the maxilla, which is usually down and back. So you're advancing the maxilla relative to the mandible, but it's always in the same direction that it's pointing. So it's already down and back, but you're trying to add in a little bit of a forward component to it, but you're always going to continue to be down. What stops that downwards and backwards rotation is a closed mouth posture. the mandible rotating up and forwards in the closed position is what stops the downward rotation. But if you're a class 3 relationship, you're already in a situation where you can't close your mouth. So there's no upward rotation force until you can jump the bite. Once you jump the bite and you start chewing in a normal relationship, then you're going to introduce an upward vector. And if you can rest with your teeth together and tongue on the palate at that point, then you'll start to change to a forward and upwards rotation. But the mechanics of the reverse face mask is forward and downwards. So you're always going to have some form of downward rotation. The teeth will erupt when you do any form of mechanics, because that's the easiest. So that eruption is downwards. And because you're pulling downwards because of the direction you're already facing, you're coming forward, but you're also going down. And going forward, when you're going down, it's a backwards tendency. What are the dental and skeletal movements expected? So we're not expecting any dental movements because we are anchoring the maxilla either through the stage 1 appliance or in older patients in more conventional approaches, the bollards, or in younger patients with conventional approach using a form of fixed RPE expander. So you're hoping for primarily skeletal movements. Primary dentition, everything softer. The expression of the downwards and backwards rotation is less, so you're going to get more forward pull in a primary dentition than older patients. So the older you are, the more the malocclusion expressed, and it's more downwards and backwards. So you expect you get a double effect of improvement in primary dentition versus mixed dentition because A, you're younger, so the bones are softer, so you get more pull effect. And because there's been less time for downwards and backwards rotation, you get less downwards and backwards expression in the headgear mechanics. Okay, so I think that's answered that one. Next question is equilibration of primary teeth in growth and development. Why is it that primary canines hold back the forward growth, the mandible, and how exactly do you determine they need to be adjusted? I know you adjust after expansion, but I'm still confused on how to determine if they need to be adjusted in the first place. For example, do you posture the jaw forward in an ideal skeletal relationship, then assess which primary teeth are in the way, then judiciously adjust these, or do you ever use turbos or composite build-up in your postural orthodontic treatment today? So, class 2 relationship, you have your lower canines behind your upper canines. In a class 1 relationship, your lower canines are slightly forward of the upper canines, and that relationship is the same in primary dentition. So your bite locks your relationship together. Primary teeth usually are worn with time. We have this impression that a good dentition is pristine and unworn, and that a worn dentition is a parafunctional breakdown. Historically, dentitions are meant to be worn with use, and part of our issue is that our teeth aren't worn. And as a consequence of us not using them, us having utensils and us having access to super high nutritional value soft foods, so we don't wear our teeth down in normal function. We get more of a forward development often when the dentition is worn through natural use, and that is the stimulation of forward vector from the teeth being worn and sliding forward. Unworn dentitions tend to hold a very static position in centric bites, maximum intercustation. And if you have a child that's class 2 and the teeth are unworn, when they close together, they're locked into whatever malocclusion they're in, and there's no forward momentum, if you like. So equilibration is usually done on children who have zero wear in their teeth. Right? You're meant to have some wear. Everything tends to flatten out by the time you get into the late primary dentition. But some kids have done so little in the way of functional activity with their teeth that they look like they're brand new despite being 3 or 4 years old. So when we have a situation after we've expanded, we bite together, our teeth are pristine, and the finished position after expansion is a heavy locked-in class 2 relationship. Usually it's the canines that are not worn in particular, and they're in a class 2 relationship. So we round off the tips to see if whenever there's any specific interference of canines from the mandible sliding forward. So we don't hold them in a forward position, but we just look for contacts that prevent a more forward position. And in primary dentition, we do tend to find that after the arch development, if we grind down some of the canine interferences, there's a tendency for the kids to slide forward a little bit, and we use that kind of forward momentum to help with growth and development. We also, at the end of expansion, need to see if there's any clashing of unworn molar cusps in the primary cusps to prevent a nice even contact. And again, based on the same principles, that teeth are meant to be a little bit worn. If there are premature contacts that prevent the solid multi-tooth contacts that we want in good bite relationships, then we'll grind down high cusps that are preventing that. So we'll grind canines, E's, D's, thing that stops a nice bite relationship. we don't do that until after we've completed our expansion. After that, we're trying to get a bite into a nice relationship. We treat primary teeth as, to some degree, the enamel being disposable. So we adjust that to prevent any locking in by canines into a class 2 or a class 3 relationship. And we equilibrate cusp tips to make sure we've got more even contacts in centric maximum to customization. Do I ever use spike turbos, composite build-ups? I tend not to. Yeah, I tend not to. Because it creates a backwards rotation. Rarely do you have to open a bite in children under the age of 10. They don't generate enough clenching force to get a short face. Bite opening tends to be reserved for older patients who have spent a long time, many years clenching and building up elevator muscles and compressing the face. Okay, so next question is, in reviewing the postural orthodontics literature from the 2-day series, I'm confused on the research supporting the significance of posture versus functional growth and development of the mandible and jaw system. Understand that postural forces are light and continuous and have more of an influence on developing neutral zone soft tissues and therefore our option of teeth at night and shape of the jaws. I understood that the function of swallowing intermittent heavy forces have less an effect on tooth eruption and jaw shapes. But when you review a paper that suggests that changing a child's swallow pattern may help correct malocclusion. So can you summarize the information to me concerning where posture really matters and where the swallow pattern really matters? Okay, so there's obviously a continuum between posture and function, right? They're all the same process, but on different sides of that continuum. You can't eliminate posture from function, and you can't eliminate function from posture, but they are two distinct, different sides of the continuum of all the activities that we do with our body. Posture favors long, continuous light activity or positions held against gravity in space. Function, shorter, sharper, heavier forces that help move us in space. And then there's a blending of function and posture from those two extremes. Case in example is swallow is a function. Posture is the position held before you swallow and after you swallow. So the static position that is maintained prior to the swallow and after the swallow. So they blend, the activities blend, but they're different, right? Another way of thinking of it is when you're speaking, you're verbalizing by opening your mouth and air is passing through. But when you finish speaking or the full stop, you stop talking and you're holding a passive position at that point. So the words are your function, but the full stop after you finish speaking is your positional posture. So the swallow is the function, and then before the swallow and after the swallow, the inactivity period is your posture. So in function, because it's such a short and relatively heavy mechanism of action, you are expending energy and you are activating muscles to move your body in space, move your jaws in space. That uses energy and it breaks down the tissues just because that's the nature of a movement. Right? There's no growth during functional movements because you are in a breaking the cell down activity. When you finish the movement and then you're holding static, is when you have an opportunity for repair and also opportunity for growth at night. Yeah? So movement or function, your body's breaking down through activity, and then posture or holding static is the opportunity for healing and growth, right? Because your body's not breaking down so much, but replenishing, rejuvenating, reforming, forming. So they're the differences between posture and function. We know that functional movements, such as the swallow, are driven by the shape of the jaws and the resting posture just before the activity starts. Assuming that we have the capacity to do different types of swallow patterns with the structure that we have, we know that if we start in a resting posture that has lips together, teeth together, tongue to the roof of the mouth, then the swallow function tends to be tongue heavy with less activity in the facial muscles and the elevator muscles of the jaws. If the posture starts with the mouth open, then we have more likelihood that we're going to have to activate the facial muscles and do a tongue thrust to be able to maintain the teeth apart relationship whilst driving food into the throat rather than out through the lips. So if we swallow using a technique that is lip heavy, cheek heavy, tongue in a sagittal movement heavy, and the teeth are apart, we end up with a finish point at the end of that swallow where the mouth is open. And if we end the swallow with the mouth being open, our rest posture tends to continue on in an open mouth position. If we swallow with our lips together, teeth together, tongue squeezing anterior, middle, back, then we finish the swallow in a fully closed position. And that swallow also creates a vacuum seal that creates a tongue to palate negative pressure. And so when you finish that swallow, you actually end up with a physiologic closed compartment in the mouth that resists gravitational forces because of the vacuum seal. And so your pause following the function of the swallow becomes a posture that is closed. We know that the function itself doesn't change the growth pattern, but the posture after the function and before the function does. If you're swallowing correctly, you tend to finish the swallow in a fully closed resting posture, And you also stay maintaining that closed resting posture because that's default is easiest because you've got a vacuum seal holding it together. So when you start the next swallow, you've had a period, relatively long period, where your resting posture is optimal. If you swallow with a non-physiologic swallow, where you're sucking the food in, or thrusting and pulling back the tongue, or squeezing the lips back, or any other variation of non-physiologic swallow, adult physiologic swallow, then you end up without your tongue on the palate, with your teeth remaining apart, and very often only incorrect lip seal. And when you finish your swallow in an open mouth posture, then there's no vacuum seal to help you fight gravity, and your mouth remains open. And then the busier that swallow becomes, and the more powerful the muscles are developed as you age, the greater the tension against your teeth during those activities. And you tend to enforce the development of facial muscles, and create a environment that enforces the malocclusion. So posture is the most important thing, but function will have a significant influence on the resting posture immediately after. Next part, you also reviewed research showing that certain occlusions, good occlusions, exhibit more physiologic swallow patterns generating a vacuum seal, whereas class 3 division 1, 2 open bites do not. But I'm getting lost in the chicken egg. Is it this occlusion structure that causes the poor swallow and loss of vacuum, or is it the poor swallow from early spoon feeding that causes the poor occlusion? So it's my belief, through what I've researched in mainstream research, as well as John Muir's understandings of the etiology of malocclusion, it's the swallow pattern that creates the bad posture that generates the bad growth. So it's the swallow that triggers it. Although it's the posture that creates the bad growth, it's the swallow that triggers the bad posture. And where does this poor swallow develop? I think that leads on to the next part of the question. It's spoon feeding. So next question is, are you suggesting that spoon feeding a 6-month-old could lead to improper transition to adult swallow, which could then cause malocclusion even if the airway is clear? The literature seems to suggest that the intermittent force of swallowing will not enough to cause malocclusion. So it is my belief that it is spoon feeding that disrupts the swallow pattern, which disrupts the posture, which is what drives the malocclusion, not the swallow per se, but the consequence of that swallow drives a poor posture, which drives malocclusion. So there are two distinct swallow patterns that are appropriate for human beings. Prior to the D's and E's erupting into occlusion, we are supposed to be breastfeeders. After the primary molars have made contact, we're supposed to eat solids. when we are edentate and breastfeeding, the swallow action is a suckling. It's facial and tongue thrust. So a lot of squeezing of the buccinators and thrusting of the tongue. That milks the breast and is appropriate for the infant and is termed suckling. Swallowing is a appropriate activity in a dentate child and adult. Swallowing, correct physiologic swallow, has been confirmed to be predominantly tongue focused with very little in the way of facial activity or elevated muscle activity. It's done with the teeth in contact, the lips sealed, and a wave squeezing from the front of the mouth at the tip of the tongue, squeezing up to the middle, and then lifting at the back onto the soft palate, activating the vagus nerve and the levator palatini type muscles, and then triggering the physiologic swallow, the vagus nerve activated swallows. That's possible when we break down food with our teeth, and we have created a swallow that combines using mastication leading up to the swallow. If we understand the timeline of human development, we recognize through research that we first develop a suckling swallow pattern. So our food is liquid in nature. Then we transition to solids. And then finally, we develop the capacity to swallow semi-solids. Right? That's actually the sequence of development in human beings. At 6 months, we only have incisors. We have no primary molars. So we're not ready for a physiologic swallow. We are still only ready for an infant suckling. But when we spoon feed, we create a situation where we force an infant to suckle the contents of the spoon. This is not a natural continuation of growth and development, all right? Because spoons are artificial structures. Historically, we have used mouth on breast or food in hand to mouth. Spoons are a relatively new invention, and physiologically, we're not designed as infants to use utensils. 6-month-olds don't have the capacity to lift the spoon and feed themselves. 6-month-year-olds are fed with adult intervention. So we will put the spoon in the mouth, and what tends to happen? The baby tries to suckle the food, and you have lots of lip and cheek activity and the tongue thrusts forward, and most of the food ends up more outside of the mouth than inside of it. But because we are instructed that this is a vital part of childhood development, we continue to insist on using the spoon to feed the infant. We safeguard against the mess coming out with bibs, but we just keep forcing that spoon into the infant's mouth until they figure out how to modify their suckling to get the food inside the mouth rather than out in the face or out in the bib. And instead of them developing a natural transition from suckling to swallowing, they have to adapt the suckling to a swallowing off a spoon, and it ends up being what John Mew termed a suck swallow. And that suck swallow becomes the new norm for the infant. And it's that suck swallow that now becomes the swallow pattern instead of the physiologic swallow. And once that suck swallow becomes ingrained, then the resting posture, which follows a suck swallow, is not ever teeth together, lips together, tongue on the roof of the mouth. It's always lips together, teeth apart, tongue kind of floating around at best. And so the posture then drives the mouth movement, irrespective of whether they can breathe through their nose or not. Next question, part of the head. If a dysfunctional swallow can cause a malocclusion, then froggy mouth introduced at 3.5 could correct this problem or redirect growth. So again, the dysfunctional swallow doesn't cause the malocclusion, but it causes a bad posture, which causes the malocclusion. So a froggy mouth forces a child to relax their lips, keep their teeth together, and swallow with their tongue squeezing on the palate. That action retrains the child to swallow physiologically rather than continue on with the suck swallow. If at 3, the occlusion is still within an acceptable range where they can swallow physiologically, then a froggy mouth can indeed be used to retrain the suck swallow, which was a consequence of spoon feeding, and direct the child back to learning a correct physiologic swallow, and then improve the posture. That's assuming that in addition to learning to swallow physiologically, that they learn to chew their food properly and break it down so that in mealtime they can swallow physiologically as well. Because you can't swallow physiologically chunks of food that you haven't chewed on. However, if the child was spoon-fed and had airway obstructions, would we expect to see a more severe malocclusion? Yeah, sure. If we're spoon-fed and then we can't breathe through our nose, so not only do we rest with our teeth apart and our tongue floating around, but we actually rest with our lips apart as well, then you're more likely to see a much more significant malocclusion because the posture has gone from unacceptable to awful. Last few questions. Why infants cannot breathe through their mouth in the first year of life? Infants can breathe through their mouth, but infants tend to be what we call obligatory nasal breathers. And the reason why they need to be able to breathe through their nose, not that they can't breathe through their mouth, it's just that they have to be able to breathe through their nose to be able to feed properly. Infants feed and breathe simultaneously, right? They've got their mouth on the breast and they're suckling continuously, and in between the suckles, without breaking lip to breast seal, they breathe through their nose because the soft palate and the epiglottis are so close together that they have airway protected so that the milk can pass in one channel and air through the nose can pass through and not intermingle, so that you don't get air in the esophagus and you don't get food or milk in the trachea. So it's not that they can't breathe through their mouth, it's just that for their survival, they have to be able to breathe through their nose so that they can feed and breathe simultaneously, which is what they need to be able to do. If you can't breathe through your nose, you won't want to feed because air is more important than food. And so you get failure to thrive. Why children cannot eat and talk when they are eating? Well, children can eat and talk when they're eating, but talking is an activity that's learned around 2 years of age, 18 months, 2 years of age. So it's a relatively new activity that takes immense focus and concentration. Eating is innate in an infant through suckling, but chewing has to be learned because primary molars don't erupt until about 18 months of age. And so you are switching from an innate suckling to a learned chewing and swallowing. At that timeline of around 2 years of age, you're learning a brand new activity, which is called talking, and you're learning a brand new activity, which is called chewing and swallowing. Now, whenever you're learning anything new, if you're not 100% focused on that one thing, you tend to lose control of all the things that you're doing. If you're learning to chew and swallow, and you're learning to talk, if you combine the two at the same time while you're learning, you tend to jumble it all up. So if you're talking while you've got food in the mouth, what are the chances are that some of that food ends up not down your esophagus to your stomach, but down your windpipe into your lungs? When that situation arises, your role as a parent is to ensure that you don't run the risk of overloading the capacity of the child to do either eating or talking, and then end up with a situation where you run a risk of choking to death. So until mastery of eating and mastery of talking is developed, it is risky for a child to combine those two activities because of the potential for choking. How long does it take? Well, usually a couple of years, right? So between the age of 2 and 4 years of age, there should be a rule that says you should not talk when you've got food in the mouth. And so we discourage children from eating and talking because they don't have the experience of control to be able to juggle eating, talking, and breathing all at the same time. And so they run the risk of choking. And so we discourage them from doing it. if we are good parents. Last question. You said the molar intrusion, when it is lower jaw backward rotation, creates headgear effect. What do you mean by headgear effect? Headgear is extraoral orthodontic appliance. So headgear effect is pulling down and forwards. That's all. Molar intrusion means that you are going to have the mandible come up and forwards a little bit. So I'm not sure if you understand that question entirely, but headgear effect is a forward and downwards rotation, and any activities that we do orthodontically tend to create that downwards and backwards action in the growth. Intruding molars is usually the opposite. Extruding molars has a headgear effect. So I think possibly that's where the confusion comes into place. Because extruding molars gives that rotation, which is similar to headgear, which is pulling down and backwards. All right, so that's gone over time, but that's pretty much all we're going to do today. Thanks for the questions.
Okay, thanks, Simon. Thanks, everyone. We'll record this and upload on our YouTube channel. See ya. Thanks. It should be available tomorrow. Bye.